So in the last Tuesday, day before yesterday, we had the MCQs on video 3B, as we call it, as I called it. It was basically on, we reached up to future vaccines. We were supposed to cover dengue also. Two most important, see, there is certain questions are repeated very often. I think because basically the examiners are lazy, they keep on putting from the previous question papers, which is good for you. The one of the topics which is often asked is, which may not be easy to answer, is future vaccine. What is future vaccine? You cannot write PCV14 or HPV vaccine because they are not future. But what do you mean by future vaccine is vaccines which are in the this one, what you call the research, and which are very important for us. Now, many of them are difficult to write because there's no proper name for them. And then they will say there are 4 vaccines in phase 1 trial, phase 2 trial. These do not give much. Therefore, you have to pick up certain important points so that if you are asked future vaccine as a full essay for 10 marks, you should know how to write it, what all vaccine you should write. Or it can be a short note on some important vaccine like malaria vaccine or dengue. Dengue, the slides I have shown, the MCQ we did not do. We will do it the next time. This time we will begin with the malaria vaccine. Okay. Future vaccines and catch-up immunization we try to divine today. Therefore, we will talk about malaria vaccine. Can you read it?
Malaria vaccine development efforts have focused on preventing illness from Plasmodium falciparum and to a lesser extent on Plasmodium vivax. Significant roles for both humoral and cell-mediated effectors have been demonstrated in animal models, and both humoral and cell-mediated immune responses are induced in humans after natural malaria infection and following inoculation of many candidate malaria vaccines, including the vaccine described below.
Therefore, this important point is to not focus on preventing illness from falciparum malaria. That's the most important. Lesser extent of Plasmodium vivax, I'm not too sure about it. Now, this guidebook has come about in 2022. Therefore, the purple book of guide, this is why it is important to pick up the source of the information. If you are asked of malaria vaccine, the better this would be the World Health Organization WHO position paper on malaria, which has come in May 2024. Therefore, we are now going away from the purple book because that is outdated. Now you read what is given in the bracket. These are from WHO 2024. That is last year. Remember, May 2024. There's just 1 year and few months. Okay, now read the essential points you should know. Okay.
Make it full screen?
What's it?
Can you make it full screen, sir?
Is it not full screen?
No, sir.
Let me see what is going on.
Sir, full screen.
Yeah, I understood. Why it is not full screen, I don't understand.
No, sir, I can see.
Is it full screen?
Yeah, now it's full screen.
I don't know why it was not full screen. Now mine is gone, I think. So Amal has come back very happy, huh? One minute. I don't know what is going wrong here. You are full screen or half screen now?
Now it's like slides only, sir, not power, that slideshow.
Okay, let me see one more. Well, I don't know what's happening here. Let's see this is what happens when you log in. You waste your time doing this and that. Your screening is paused, but I'm not getting the full screen here. Yeah, let me see here. One minute. You're getting full screen now?
No, sir.
No?
But I can read, sir. I will read.
No. There's a long way to go, is it not? Why should we be?
Mhm.
I know suddenly it has become your screening shot, it is written, but it is not coming full screen, is it not?
Yes, sir.
Is it screen or slides only?
It's slides only, sir.
I think I will close the presentation. I'll close the. Is the Zoom also gone? Are you listening to me? Can you hear me?
Yes, sir. I can.
Okay, your screen. I will close all the once restart it and see what happens. Do you want to make the berm? Don't save. Okay. Now, Gopika, now screen sharing has been stopped. Okay. Now I will go back into. Are you seeing full slide? No, you're not. I'm not this one. Share screen, power slide. Share. Can you see now?
Yes, sir.
Full slide.
Yes.
Okay, now. Okay, then let's go to. So malaria vaccine. Therefore, we are slipping into what you call as. I think the recording is the recording going on. Let me see whether the recording is going on. All the problem is because you log in so late. You come so late, therefore, if there is a delay, everything goes upside down. I think I'm logging. Am I stop share your sharing screen? Stop share. And what about recording? Is it recording? Show meeting remote control more. No, I think it's recording. Okay. Therefore, we go to malaria vaccine and we said that we will take it from the 2024 WHO, this one. Now read it. Full slide.
The currently recommended malaria vaccine are safe, efficacious, and impactful against uncomplicated or severe malaria and death. WHO recommends the use of malaria vaccine for the prevention of Plasmodium falciparum malaria in children living in malaria endemic areas, prioritizing areas of moderate and high transmission. Malaria vaccines should be provided in a 4-dose schedule in children from around 5 months of age. The minimum interval between any doses is 4 weeks. To achieve prolonged protection, the fourth dose should be given 6 to 18 months after the third dose. Malaria vaccines should be provided as part of the comprehensive malaria control strategy. All malaria control interventions, including vaccines, provide partial protection. The highest impact is achieved when a mix of intervention is used.
Remember, therefore, you must catch the points of malaria vaccine. Therefore, you will have to write for 5 or 10 minutes. You are not going to administrate from the practical point of view, but you must know where it stands. Therefore, 2024 WHO summary is the most important thing. It gives the vaccine is effective only against the malaria falciparum. That the user map, it is recommended prevention of falciparum in children living in children, remember, in malaria endemic areas, moderate and high transmission only. Unlike other vaccines, a 4-dose schedule, from around 5 months of age. That is very important, 5 months of age. Just like influenza is at 6 months, malaria is at 5 months. Therefore, everything has got a change. And the last dose, that's the fourth dose, should be given at 6 to 18 months of life. That's equal. Now, next come. They have given beautifully. Okay, read what is given in the bracket only. Has it changed?
Yes, sir.
Read it.
Malaria vaccines.
Yeah.
2 malaria vaccines are WHO recommended and pre-qualified. Both are pre-erythrocytic vaccines that prevent P. falciparum malaria in children. The recommended malaria vaccines are not designed to interrupt the malaria transmission, and there is no non-cross protection with other non-falciparum plasmodium species.
You can read the last dose, okay? The last sentence.
Malaria vaccines are administered intramuscularly in a 4-dose schedule.
The vaccines, to know the name is difficult. One is RTS-S. I will highlight it for you. RTS-S is 001, and this name, if you can remember, it's great. Now the highlights, they have put it on the right side. You can read it again. Key takeaways. Can you read it? Hello, can't you see that? On the left of the screen or the right of yourself?
Sir,
Yes, sir.
currently available malaria.
Okay.
The currently available malaria vaccines are safe and life-saving. The pilot introductions of the malaria vaccine reduced all-cause mortality by 13% in children aged eligible for vaccination.
See, remember, it reduced all-cause mortality. Remember, it's not malaria vaccine mortality. It's very important to understand that. In malaria endemic areas, prevention of malaria is not only causes the decrease in mortality of malaria, it causes all-cause mortality, because children who recover from malaria will have anemia, immunity problem, they may develop a pneumonia and die. Therefore, malnourishment it may precipitate. For all this, everything is a point, okay? Read it.
Both recommended malaria vaccines are safe and efficacious. Malaria vaccine should be provided in a 4-dose schedule in children from 5 months of age. The minimum interval between any doses is 4 weeks. However, to achieve the prolonged protection, the 4th dose can be given 6 to 18 months after the 3rd dose.
Okay, read on the right side. There's no problem in reading twice. Read it. Key takeaways.
Malaria vaccines are recommended for the prevention of Plasmodium falciparum malaria in children in endemic areas, prioritizing areas of moderate and high transmission.
Okay. Okay, read it again. What's it?
Schedule. Malaria vaccine should be provided in a 4-dose schedule in children from around 5 months of age. Countries may choose to give the first dose earlier than 5 months to achieve the increased coverage or impact. The minimum interval between any doses is 4 weeks. However, to achieve prolonged protection, the 4th dose can be given 6 to 18 months after the 3rd dose. There can be flexibility in the timing of 4th dose, including by aligning it with vaccines given in the 2nd year of life to improve the coverage, giving it just prior to seasonal peaks in malaria transmission to optimize vaccine efficacy. A 5th dose given 1 year after the 4th dose may be provided in areas of high seasonal transmission or in other areas where the significant malaria risk remains for children. Key takeaways. Malaria vaccine should be provided in a 4-dose schedule from 5 months of age. Minimum interval between doses is 4 weeks. There can be flexibility in the timing of 4th dose to improve coverage or efficacy.
See, this was a little surprising to me. They say 5 months, and then they say may choose to give the first dose earlier than 5 months to increase coverage or impact. That means 6, 10, and 14 weeks when you give it at 14, because there's no other immunization at 5 months. You understand that. 5 months is 20 weeks. We are giving it 14 weeks in all developing countries. Can it be given at 14 weeks? I'm not too sure. But they say there can be flexibility in the 4th dose. All right. Therefore, there are 2 ways: by age, by season. Season means just before the rainy season, you may give it. Okay. Read it. What is in the bracket here?
Areas with highly seasonal malaria transmission or perennial malaria transmission with seasonal peaks, country may consider using an age-based or seasonal approach or a hybrid of this approach, giving the first three doses age-based and the subsequent annual doses seasonally. At the time of vaccine introduction, catch-up vaccination can be considered in children up to 5 years of age, subject to local epidemiology and age of high risk, feasibility, affordability, and the vaccine availability. Key takeaways. In areas with highly seasonal malaria, countries can use an age-based or seasonal approach or a hybrid of the 2 approaches.
Okay, therefore you have got enough points to write at least for a 9-mark question or even a 5-mark question. Yes. Read it.
The malaria vaccination series for each child should be completed with the same product whenever feasible. Key takeaways. If a prior dose is unavailable or unknown, the series can be completed with either vaccine. Restarting vaccine series not recommended.
This is the this is the schedule, general advice for most of the vaccines. Give the same type, but if it's not available, you can complete with somebody else, some other vaccine type. Okay.
Both vaccines are considered to be safe and well tolerated. There is a small risk of febrile seizure within 7 days, mainly within 2 to 3 days of vaccination. Takeaways. Recommended malaria vaccines are safe and well tolerated and may be administered with other childhood vaccines.
Remember this, that in a malaria endemic area, if a patient has fever and convulsions, taken straight away as cerebral malaria. Because from the time you diagnose to the time the child dies may be hours. IV quinine in cerebral malaria is an emergency. You must know the treatment of malaria when you go for examination outside Kerala, especially. Amal, where you asked about malaria?
No, sir.
Rakshapattu. I was worried they will ask, because malaria, cerebral malaria, is a huge problem. It is not that common in India as it is in Africa, but it does happen. In children have fever, they are dead within hours, just like meningococci. And even there have been reports from Africa where a doctor who sees patients and he develops a fever 40 halfway through his clinic, and he's dead by the end of the time of his clinic. Therefore, that is so fast the malaria kills. Therefore, here, if you give a malaria vaccine, the child develops a fever and convulsion, you will take it immediately as a cerebral malaria. But then you remember that it can be febrile seizures also. Read only what is bracketed.
Both malaria vaccines can be used in malnourished children. RTS/AS01 can be given to HIV-infected children. Malaria vaccines are not indicated for adults or travelers.
All these are points. Therefore, these points alone you remember. The maximum you can get is a short note on malaria vaccine. I don't think they will ask a full essay. Okay, take away what is written on the right. That is enough.
Malaria vaccines should be provided as part of a comprehensive malaria control strategy. Malaria vaccine visits are opportunities to provide other health services.
Okay, the other things like you have to provide net, you have to mosquito net, you have to not to have ponds nearby with mosquito breeding. Everything is important, because what you are giving vaccine is only for falciparum. Vivax and other malaria will not be prevented. Remember that. And therefore, you must know all the points of writing the malaria vaccine. I am not going into it. I think when you present a paper, and if I had asked you to talk about malaria vaccine, you would have taken from the purple book and presented. When you are a postgraduate, you should just put it on I just put it on the Google and said WHO question paper malaria. I was surprised that there was a very beautiful presentation of 2024. But that's the points from this is more than important from your examination angle. Examination. Now you must know the other vaccines which are future. Dengue and malaria are the most important vaccine. The other vaccines which are important. See, what happens is that when you are asked to put up, if suppose somebody asked me to put a postgraduate question paper on this, I have to put a question from immunization. Therefore, generally they try to put something different, like immunocompromise, where patients with adolescent immunization. And one of the most common topics which is put up is future vaccines. Therefore, you must know at least the terms and write 1 or 2 sentences about them. Now, next is human immunodeficiency virus vaccine. Can you read this from the IAP guidebook?
Human immunodeficiency virus vaccine. The extraordinary genetic diversity and the high mutability rate of the virus and its capacity to evade and escape inside lymphoid and the macrophage cells and the tropism of the virus for T helper cells facilitating infection, spread and persistence are some of the obstacles researchers face in the development of vaccine against HIV infections. Nevertheless, the possibility of T cell based or broadly neutralizing antibody based vaccine holds promise and the cornerstone of future research. Cornerstone of
future research. Therefore, you can just write 2 sentences about it. That what it means is there's no vaccine available, from at least from what I could understand, because of the high genetic diversity and the mutation, high mutility rate. That's why the human immunodeficiency virus is very, very difficult to treat also. Nowadays, of course, they have got treatment. Therefore, this is the reason vaccine is not, at least this much you must know to write. Next.
Respiratory syncytial virus vaccine. Currently, there are at least 7 investigational RSV vaccines in clinical development, including live attenuated, vector-based, particle-based, nucleic acid and subunit vaccines. Target groups include pediatrics, elderly, and maternal immunization to protect the infant. An effective antiviral response following an RSV vaccine must include a prolonged neutralizing antibody response, Th1 polarized immunity that promotes both CD8 plus and CD4 plus T cells, type 1 interferon secretion, and an efficient mucosal immune response.
Now, therefore, you must know that there is they are looking for investigation only, all the types of vaccine, live attenuated, vector-based, particle-based, subunit vaccine there. The target is not only pediatric patient, internally and maternal immunization. Why is RSV a very important cause? Should you be, in which type of children are you very worried about RSV? RSV is the commonest cause of bronchiolitis, is it not? Very common cause of infant viral infection. Should we be concerned about it, Gopika? Is there any concern? I have said this many times. I am telling you it again. Amal, Parisha paasayalum ividathilla alle. I will not leave you. When is your last day? Amal, when is your last day posting? I can't hear you. Unmute yourself. Unmute. You are muted now.
September 1, sir.
September 1. Therefore, I won't see you. You have to go and join back in the health service, I suppose. Am I right?
That is 1 week after.
1 week after. Okay. Now, tell what was I asking you? Which type of children will you be worried about RSV infection? I told you several times this. Okay. This may not be important from the what you call the slide point of view, but from the nobody will ask you in the exam probably. From practical point is very important. Gopika, what do you say?
For immunocompromised infants.
Yeah, that's a very broad statement. This is what will come. I know that. The most important is preterm babies. See, Gopika, you are there. You see a patient with Karthik discharge, the baby was 800 gram or 600 gram. He did this, he did that, and he saved the patient. And when they went home in Western countries and all, if the patient is there for more than 2 months, when they go home, they celebrate. They have a big celebration. And in the Gulf, they put it in the paper, 600 grams baby went to. But the problem is a child develops a respiratory syncytial virus infection. The mother may just come to you and say, Doctor, the last feed he did not take. He's not the same, but he's okay. He's crying, breathing, everything. That is enough. That is enough. The child will have an apnea and die within hours. Therefore, respiratory syncytial virus can be devastating in ex-preterm babies. Therefore, whenever you find a child who is discharged from the SCABU within a period of a week or 1 month, he is less than 2 kg, comes to you with such a complaint, immediately admit the patient. What do they do in Western countries for these patients, Amal? What do they give? I asked this question. There's a very major emergency even in the Gulf. And because it causes terrible problems, the parents will never be understanding it. How did they suffer for 6 months where a child is reborn and within hours, within a day, it will die if it develops an RSV at home? Is there any prophylaxis for it?
Yes, sir.
What is it, Ashwari?
Palivizumab.
Very good, Palamixam. It's called, it is given in Nelson. You don't open it. Amal, you went for the exam without opening the Nelson's textbook of pediatrics. Probably the examiners now also don't open it. Palmiximab is something which is given. That's what is Palmiximab, Ashwati?
Monoclonal antibody.
Monoclonal antibody against RSV is very, very, very costly. I asked one neonatologist, I am not too sure. Is it being given? He said it's not available in India and it's not a problem here. But I will not agree with that. Remember, in your practice, tomorrow you go and sit in a clinic. A patient is discharged from KIMS. They would have paid lakhs and lakhs of rupees for the care. Come to you with cold. Just running nose in the mother. The child comes with a little blocked nose and says he's not normal. Tell the patient, rush him to the KIMS hospital back. This is because next day morning he'll be dead. If you miss him in the night, he will die. Therefore, every URI in a newborn or an infant is an emergency. Ex-preterm, especially very bad, is a real emergency. That is why, to overcome this, because monoclonal antibodies are so sick, they want to give a vaccination to the mother or child, pediatrics. That's why this RSV is coming up. Therefore, you can write this. Now, what is the most common cause of blood transfusion? If you give a blood transfusion, which is the commonest type of disease that is transmitted nowadays? See, when you give a blood transfusion to a child, okay, it is not something you should take it very nicely, very easily. It is just like an organ transplantation. People will say now it is very, very safe, nothing problem. We are screening for HIV, we are screening for HBsAg. Therefore there is no bloodborne transmission. What diseases can be transmitted by bloodborne even when you have screened everything in PRS hospital? Gopika. Please unmute and answer. Huh? Amal, can you answer?
Hepatitis C virus.
Hepatitis C, any other one? HIV can, because if the donor was taken in the window period of his HIV, you can still transmit HIV. Hepatitis C is the most important. Now we'll look at hepatitis C. Read what is highlighted.
Hepatitis C virus vaccine. HCV infection can potentially progress into liver cirrhosis and hepatocellular carcinoma. HCV vaccines have been developed. None of them have proceeded to the late clinical phases. A major hurdle of HCV vaccine development is the introduction of protective immunity against this virus, which has high genomic diversity.
Okay, the hepatitis C virus, till date, no effective vaccine is licensed. But there's a treatment for hepatitis C, mind you. Hepatitis C, there's a treatment, and it can cause the same problems as hepatitis B, though it is not that prevalent. There's no vaccine available till date. According to the Purple Book, I'm not sure what Lancet and New England Journal says. High genomic varieties are responsible for that. Therefore, whenever you give a blood transfusion, ask you 100 times, should I or should I not? If it is not necessary, don't give, because you can get hepatitis C. Ebola virus vaccine. Just know the name. No approved. Read it fast.
No approved vaccines are available to prevent the spread of Ebola virus. However, during the epidemic in West Africa, accelerated paths were developed for vaccine testing and introduction into field use.
But I think nothing is available. Now, the next vaccine you should know something is about tuberculosis vaccine. This can be asked as a short note. By being tuberculosis vaccine, we are not talking of BCG. Remember this. Therefore, read through it in case it is asked. Read through the whole thing.
As on date, there are 14 tuberculosis vaccine candidates in clinical trials. These include vaccines based on subunits, whole cell mycobacteria, mycobacterial fusion proteins in new adjuvant formulation, and recombinant live attenuated or replication deficient virus vector expressing one or more Mycobacterium tuberculosis protein. 3 vaccines are in phase 3 trials. These include recombinant BCG, VPM 1002, which is being assessed in newborns as a BCG replacement, in adolescents and adults as a BCG booster, and as a therapeutic vaccine. Mycobacterium indicus prani MIP vaccine by Cadila and Indian Council of Medical Research, ICMR, is the heat-killed MIP vaccine approved by the Drug Controller General of India and FDA as an immune therapeutic and immunoprophylactic adjuvant therapy in multibacillary leprosy patients and for preventing the development of leprosy among close contacts of leprosy patients.
Therefore, the Mycobacterium indicus prani is a vaccine which is for leprosy. It's a treatment as well as, but it's important because ICMR is involved in it, and it is by the approved by the Drug Controller of India and FDA, mind you, as a replacement. Therefore, these include the recombinant BCG vaccine. The live attenuated vaccine is what Bacillus calmette-guerin is. What do you mean by recombinant? Lasima is there or gone? Hello? People come half an hour late and they disappear 2 hours early. Okay, Gopika, can you answer?
Yes, sir.
Gopika, unmute. You are muted, Gopika. Yeah. You are now, yeah, okay. What did I ask you? I forgot what I asked you also. What do you mean by recombinant BCG? Hepatitis B recombinant virus. What do you mean by that?
We'll make the vaccine from we'll introduce a gene, like an antigen from a pathogen, and we'll produce a immune response from a.
Yeah, I don't know much about this recombinant BCG. What you part of the organism or a DNA fragment of the organism is introduced into another, this, for example, rapidly multiplying cell. Like, recombinant BCG is the tubercle bacilli DNA is in. For hepatitis B, I can say hepatitis B, the DNA, part of the DNA of the hepatitis B is introduced into the yeast cell. And therefore, the yeast cells start multiplying and produce these hepatitis B surface antigen, which is then becomes immunogenic. Therefore, it is introduced. The recombinant means it's a combination of 2 DNA. Now here, is also a subunit vaccine. But remember, there's something about tuberculosis, leprosy, recombinant BCG is used. Mycobacterium indicus prani is important because it is Indian Council of Medical Research which is maintaining it. It is FA, it is Drug Controller of India and FDA is approved. It's a heat-killed vaccine, straightforward, heat-killed vaccine. That's what it is. Okay, now next. Can you read it? Yeah.
The phase 3 trial in India is investigating the efficacy and safety for the prevention of pulmonary TB among healthy household contacts of sputum smear positive TB patients. Mycobacterium vaccine which is inactivated Mycobacterium vaccae is licensed in China as a therapeutic vaccine to shorten the TB treatment for patients with drug susceptible TB.
Therefore, the Mycobacterium indicus prani is not only for tuberculosis, but also safety or prevention of pulmonary tuberculosis also in healthy household contacts or sputum positive patient is being. If I catch some points so that you know to write a paragraph about tuberculosis, alternate tuberculosis vaccine also. Now, two more names is very important, Shigella and E.coli. Just remember the name, at least read through it fast. You must know what it is. Sorry. Yeah.
Shigella vaccine. Shigellosis is an important cause of morbidity and mortality, particularly in children less than 5 years old in developing countries. Several vaccines are in various phases of clinical development. E. coli vaccine, the majority of enterotoxigenic E. coli vaccine candidates currently under development use various platforms to induce anti-labile toxin and anti-colonization factor or coli surface antibodies. This will result in thereby blockage of adherence to the intestinal lining and pathogenicity.
Okay, the names are important. Just the names you can remember: Newer vaccine, dengue, and malaria. After that, you remember about tuberculosis. After that, you remember about Shigella, E. coli, and the previous one was Ebola and hepatitis C. Therefore, if you remember the names, you write one or two sentences, you get. But the very important vaccine is Group B streptococcal vaccine. Okay. Now, my question is, during pregnancy might produce susceptibility to invasive disease, but no licensed vaccine exists. Why is it so important that to have an immunization in against Group B streptococcus? Have you ever found a single patient with Group B streptococcus disease? What? Suppose I ask you, why is it so important? Amal, you are passing out of the DC. Okay, Gopika, say, go ahead. Unmute and talk, please.
To prevent renal complications.
We are giving vaccine to the newborn and or to the mother. That's what we are talking about. What renal complications are? How does Group B streptococcus
So
happen?
for mother, it is to prevent the transmission of the bacterial infection to the newborn during delivery.
Does it do anything to the mother?
No.
Now, suppose there is a newborn baby and he has developed Group B. Have you ever seen a Group B streptococcal infection in newborn? Go and ask the PGs in SAT hospital also, they will say no. Most likely the consultants around you will say no, it is not present. No, doctor, there's no Group B streptococcus. But the problem is if you don't get cultures positive, you will never get. How does it present actually? Group B streptococcal is supposed to be a very devastating illness. I have seen at least one case, and the other case was culture positive. The thing is that suddenly the child, newborn baby, fully grown, well child, suddenly goes into shock, early shock, and develops what you call cyanosis, pulmonary hypertension, similar to meconium aspiration. But unlike meconium aspiration, this child will go into shock and it can die. Now, for that, there is a preventive measure which is done by the gynecologist now. What is it? Amal, do you know about it?
High vaginal swab.
High vaginal. Are they doing it now? Here?
In KIMS, they are doing so.
Not in PRS? Gopika, they did it. Ashwati, are they doing it?
No, sir.
Lasima, finally you re-entered. Okay. Lasima, they are not doing it here. Do you think it is necessary? Because I asked the neonatologist, they say it's not important. When you don't get even a single case in which the blood culture is positive, how are you going to diagnose it? Anyway, that's a very important thing that they are missing. Group B streptococcal, the high mother, they are doing what is called maternal high vaginal swab. If it is positive, high doses of penicillin are given to the mother. Okay, that's very important. Newborn baby, what does it produce? It produces what you call as early neonatal mortality, stillbirth, and premature birth. They are suspecting premature birth and stillbirth. Therefore, your high vaginal swab is going to prevent only infection in the baby. But what is happening in the mother, like stillbirth and prematurity, will not be prevented by your antibiotic production. Therefore, for that, the vaccine is necessary. Now you read through it, okay?
Group B streptococcus vaccine. Maternal immunization against Group B streptococcus during pregnancy might protect the infants across the period of susceptibility to invasive disease, but no licensed vaccine exists. Third trimester stillbirths and the increased probability of early onset sepsis in preterm neonates led to the hypothesis that Group B streptococcus may initiate preterm labor. Currently, no one involved in the care of pregnant women or young infants would question the impact of Group B streptococcus as a cause of disease, disability, and death. Guidelines were based on the
Okay, go ahead. Okay, go ahead.
Guidelines were based on the results of trials in 1980s that identified women with Group B streptococcal colonization late in pregnancy and interrupted vertical transmission to their neonates through intrapartum administration of high-dose intravenous penicillin or ampicillin.
Now, I want you to note what's the reference to this, not the first paragraph, all the other paragraph R2. R2 is reconciled New England Journal 2023. Therefore, there was a New England, I think it was a editorial in which they sees why the vaccine is important and your antibiotic profile. And I want to stress whenever you talk to the gynecologist also, no one involved in the care of pregnant women or young infants would question the impact as a cause of disease, disability, and death. That's what New England Journal writes. But somehow they have not seen the PRS hospital. Anyway, I'm not blaming PRS hospital. I have talked it across the neonatologists in Kerala. They all are very clear. Group B streptococcus is not common. Listeriasis is non-common in newborn, etc., which I am not too sure. Okay, now come next. Can you read it?
Group B streptococcus vaccine, although the public health victory is an important step forward, it addresses only one portion of the continuing perinatal disease burden from Group B streptococcus, leaving third trimester stillbirths, maternal invasive infections including sepsis, residual early onset cases, and all late onset infant diseases unaffected.
Okay, therefore there's another thing, and also the problem, there might be a question mark on preterm delivery also. Okay, now this much we presented again from the New England Journal. Read it now.
Group B strep
Yeah, read.
Group B streptococcus vaccine. Natural history studies have correlated serotype-specific anti-capsular polysaccharide IgG in newborn with a reduced risk of Group B streptococcal disease. A hexavalent cross-reactive material 197 glycoconjugate vaccine is being developed as a maternal vaccine to prevent invasive Group B streptococcus in young infants. Multiple phase 1 and phase 2 clinical trials of capsular polysaccharide tetanus toxoid conjugate monovalent vaccine that validated safety and immunogenicity, placental transport of maternal antibodies after vaccination, and in vitro killing of Group B streptococcus by serum samples obtained from infants born to vaccinated women.
Okay, therefore, this is some detail about it, but I don't think it is very much important. What is important is there is a vaccine which is being done. Serotype specific anti-capsular polysaccharide developed as a maternal vaccine. Remember this, at least this much you remember. Okay. And now we catch up to the other vaccines in development, just the names.
Other vaccines in development include vaccines targeting hepatitis E, Staphylococcus aureus, cytomegalovirus, Epstein-Barr virus, Group A streptococci, and vaccines targeting the neglected tropical diseases.
Okay, this is the most important point. Therefore, we are finishing with the future vaccine with this. You might, as I said, from the practical angle, it may not be very important, but because the vaccine are not available in the but it's from the examination point of view, you must know about malaria vaccine and dengue vaccine, and something about hepatitis C, streptococcal, at least the name Shigella vaccine, E.coli vaccine, Ebola virus. What's the status of it? One or two sentences about it. Okay, that's what the idea. Now we take up to one book. See, the next topic which I take up is really surprisingly, it is only one or two questions I found in your DNB. It was very, very common question when we were appearing for oral in TCH and MD. They will give you a paper and ask you, doctor, this is a 7-year-old child who is unimmunized. Write down the immunization schedule for this patient. And as you enter the oral, the person there will give you this while he will be conducting the oral for the next previous candidate. As he moves in, you have to enter and give the catch-up immunization. It's not that easy. It has become more complicated over the period of time because you must know the upper age limit and the lower age limit at which you can give the vaccine. When are they indicated? When are they not indicated? Now, let me begin by asking you, these are very practical questions, but I didn't find any questions from catch-up immunization in your DNB, or if I was an examiner, instead of keeping an MRI, I would have kept in a station catch-up immunization. Now, you can read through it fast. Yeah.
Catch-up immunization. Missed immunization does not require restarting of the entire series or addition of doses to the series for any vaccine in the recommended schedule. 2 or more inactivated vaccines can be given simultaneously or at any interval between doses without affecting the immune response. An inactivated vaccine can similarly be given simultaneously or at any interval with a live vaccine. However, 2 live, intranasal or injectable vaccines should either be given simultaneously or at least 4 weeks apart. If a dose of DTP, IPV, inactivated polio vaccine, HIB, pneumococcal conjugate, hepatitis A, hepatitis B, human papilloma virus, MMR or varicella vaccine is missed, subsequent immunization should be given at the next visit as if the usual interval had elapsed. For rota vaccine, same principle can be followed, so upper age limit of last dose should be maintained. Minimal interval recommendation should be followed for administration of all doses.
All this you will be knowing. I am not going to interfere and say anything. But the catch-up immunization not only occurs in unimmunized, it can occur in partially immunized, number one. Number two, it can occur after, as we have seen, after bone marrow transplant. It can occur after solid organ transplant. Therefore, the catch-up immunization will have to be given in these instances. And the pregnant women, when they come, if they have given immunization in the period or not, then adolescent immunization. Adolescent immunization also is a very important topic which is asked. And by the way, I have given the topics. Start preparing now itself. 2 weeks, I will give you the time. You will send back to me the PowerPoint presentation topics which I have sent to you. I will go through it and then you will present it in our class. Okay. Only the MCQs I will ask about it. Now coming to the hepatitis B vaccine. Can you read it now? This is something which is a revision like, but read through it. Hello?
Hepatitis B. The hepatitis B vaccine administered according to a 016 schedule should be offered to all children and adolescents who have not been previously vaccinated with hepatitis B vaccine or whose vaccination status is unknown or where the administration was inappropriate. Pre-vaccination screening with anti-HBsAg antibodies is not cost effective and is not recommended.
This is from
So
the,
hepatitis B.
yeah, okay, read it.
Hepatitis B, minimum age for dose 1 is birth. Minimum interval between doses. Dose 1 to 2 is 4 weeks. Dose 2 to 3 is 8 weeks and at least 16 weeks after the first dose. Minimum age for the initial dose is 24 weeks.
Final
Dose
dose.
3
Minimum age for the final dose.
the final dose is 24 weeks.
24 weeks.
24 weeks.
Okay. Now, what you should understand here is that the second paper, the white one, is coming from the up-to-date, which is the United States 2025. I keep on talking about this because this is not being followed by us. We give the last dose as 14 weeks, and therefore, and the minimum age between the first and the last dose, 16 weeks, 4 months, is not also followed because the last dose is given at 6 and 14 weeks is before 4 months. 16 weeks is 4 months. We are giving it 6, 10, and 14 weeks. Therefore, everything we don't follow, universal immunization program, as well as IAP. It doesn't follow it. Therefore, we are not going by the principles properly. I stated it again and again. That's why I put it up here. Okay. Now I'll ask you a question. Now, since you have started this, okay, now schedule for DTwP, carry on.
DTwP, the schedule for catch-up vaccination is 3 doses at 0, 1, and 6 months.
Okay.
The second childhood booster is not required if the last dose has been given beyond the age of 4 years. DTwP is not recommended in children aged 7 years and older due to increased reactogenicity. It's essential to immunize even those recovering from DTP as natural disease does not offer complete protection. So, minimum age for dose 1 is 6 weeks. Minimum interval between doses. Dose 1 to 2 is 4 weeks. Dose 2 to 3 is 4 weeks. Dose 3 to 4 is 6 months. Dose 4 to 5 is 6 months.
Okay. Now here, what you should understand here is, even if you have a diphtheria or a tetanus, hopefully not, and a pertussis, you should, when you discharge the patient, you will vaccinate him because the disease does not cause lifelong immunity. At the same time, a viral disease like measles, mumps, you may not vaccinate him because it does produce immunity. And it does not produce immunity against that. That's the reason that is given. Okay. Now,
Tdap recommendation for adolescent. A single dose of Tdap may also be used as a replacement for TD or TT booster in adults of any age if they have not received Tdap in the past. Tdap can be given regardless of time elapsed since the last vaccine containing TT or diphtheria toxoid. There is no data at present to support repeat doses of Tdap. Indian Academy of Pediatrics recommends decennial TD booster for those who have received 1 dose of Tdap. Only containing vaccine should be used for vaccination in those aged more than 7 years.
all the points are very, very important. What is decennial TD doses? What is decennial? Every 10 years. Okay.
10 years.
Okay. Remember that the usual recommendation of the Indian, what you call the national recommendation is to give a DTwP at the 5 years and to give a TD at 10 years. And then onwards, they don't give anything. They don't advise anything before that. But the Indian Academy of Pediatrics says give a Tdap at 10th year, Tdap, and then onwards, don't repeat the Tdap, give only the TD. Why? Because of the cost. They found there's not much of use of giving Tdap again. But if you don't look at the cost, you can repeat Tdap only. But remember what exactly is the recommendation. only a single dose of TDAP is advised. What's the difference between TDAP and TDAP means tetanus full dose, diphtheria and SLA pertussis vaccine are lower doses. What is the dose per se? I don't remember. That's how it is. And that's now you read all this. Okay, now recommendation for adolescents and adults continued. Can you?
Tetanus and diphtheria vaccine. This vaccine is indicated as a replacement for DTwP, APDT for catch-up vaccination in those aged above 7 years, along with Tdap, and as a replacement for TT in all situations where TT was previously recommended. In individuals who have completed primary and booster vaccination with TWP, DTAP, TD booster every 10 years provides sufficient protection.
Okay. Therefore, if a patient is coming to you with the booster doses of TDAP and comes not only for the other unimmunized or partially immunized, it comes when you have an injury also. We have told about it, but we will revisit that topic again. Now, in the individual completed primary doses, they say TD at 10 years, but if you can afford, TDAP is always better. Sufficient protection. Okay. This is all we know. Read it.
Evidence suggests that tetanus is highly unlikely in individuals who have received 3 or more doses of the vaccine in the past and who get a booster dose during wound prophylaxis. Hence, passive protection with tetanus immunoglobulin is not indicated in these patients, irrespective of wound severity, unless the patient is immunocompromised. For children who are completely unimmunized, catch-up vaccination should be provided by giving 3 doses of tetanus toxoid containing vaccine at 0, 1, and 6, depending on the age of the child and nature of the previous doses received for more comprehensive protection. For partially immunized children, catch-up vaccination entails administration of at least 3 doses of tetanus toxoid containing vaccine, including previous doses received.
Can you read it? Yeah. Children with yeah.
Children with unknown or documented history should be treated as unimmunized.
All right. Now I will ask you a simple question. You are called. I have asked you several times this question, but since most of you don't attend all the class, I'm asking you. You find a child who's 7 years old. Okay, 7 years old, and the patient has been immunized at the age of, say, 6 weeks, 10 weeks, 14 weeks with pentavalent vaccine, which is available. Then at 1.5 years, DPT has been given. He missed the doses 5 years. He comes at 7 years with a road traffic accident. Gopika, what will you are called to the ER. The ER people now don't ask your opinion. That's a different matter. In case they ask your opinion, does this child require TT or not? What will you say? TT is not available, TD should be given. He's 7 years old.
After 7 years, TD is required.
Okay. Does he require it? Road traffic accident.
Yes.
Yes.
Sir.
Yes, sir.
Yes, sir. Okay. Road traffic. Suppose it's a clean wound.
Yes, as child is not immunized at the age of 5, you have to give.
You have to give. Now, suppose the child has been immunized at the age of 4 years and he comes to you 5 years and he comes at 7 years with a road traffic accident. Does he require TT? I discussed this in many ways. Yeah, okay. Does he require or does he need require?
No, sir.
See, you are, where is Amal? Amal ran away, I think. Everybody comes and once somebody joins, they leave the place. Can't even sit for 2 hours. Ashwati, what do you say? Your seniors don't seem to be very sure of what they are talking. Remember, this is a final opinion for yours. You can't Google and find the answer to this. I challenge you. Google and find the answer is not easy. What you say has got medical legal significance. To give or not to give. A patient with a road traffic accident, fully immunized, 5 years also. Well, I'll read through all those things, go through this. This is what is given in the purple book in the page. I have written even in the page 179. Okay, read this carefully. Doses of TT, clean or minor wound, all of the wound. This is ambiguous. I didn't understand what this means. Can you read it? Yes, can you read?
Yes, sir. Doses of TT,
Yeah.
if unknown or less than 3 doses and immunodeficient, TD or TDAP we have to give. Immunoglobulin also, clean and minor wounds. All other wounds, TD or TDAP, if given in past, tetanus immunoglobulin.
What does it mean given in past tetanus immunoglobulin? I didn't understand. Anyway, that I think is a mistake. In fact, in OP guide, they're given it better. I just want to say the purple book is red book, you can call it, because it makes a lot of mistakes. Anyway, this is not very clear. I'll come to that again. In what it means is less than three doses. If the patient has taken 3 doses, is considered as fully immunized. Remember this. Here is written more than 3 doses. TDAP, TT no, TIG no. All other wounds also no. Okay. Only thing is here this becomes positive. 10 years have lapsed since the last dose. Therefore, if the patient has taken 3 doses, 6, 10, and 14 weeks, the patient is 11 years old, you might give. Is 9 years old, even if the patient has got what you call serious wounds, you will not give. Minor wounds, for example, clean wound, more than 3 doses, yes, if more than 10 years. And here it is, yes, if it is more than 5 years. Road traffic accident, after 5 years, you will give. And in a clean wound here, this positive should have come here. I think I don't understand what you mean by doses of TT. If they have given dose within the period of 10 years, you will not give minor wounds. For all other wounds, if it is given within 5 years, you will not give. That's the answer. Okay. Therefore, they are basis not only on and what is immunized and unimmunized, less than 3 doses, 3 doses or more. That's all. Okay. This is how it is taken. This is given by the purple book. Or in other words, this actually, see here, there's another mistake I am adding on here. Less than 3 doses and immunodeficient. No, it should have been or immunodeficient. Am I right? Am I right, Gopika? What does it mean by unknown, less than 3 doses or immunodeficient? And immunodeficient. I mean, only if they are all together, you will consider this. No, I think it should have been or. It's a mistake here. Anyway, let's go ahead of it. Therefore, the summary is, can you read the summary?
In a child fully immunized, more than or equal to 3 doses of TT, no TT or tetanus immunoglobulin for clean and even all other wounds, provided 10 years have not elapsed since last TT for a clean and minor wound, and 5 years for all other wounds. In children with incomplete TT prophylaxis, that is unknown or less than 3 doses or immunodeficient, both TT and immunoglobulins are indicator for all wounds.
This is what it is. Even if it's a clean wound, he has received only less than 3 doses. That's a primary immunization is not over. TIG is not indicated. This is given by the purple book. Now, if you go next, there's another emphasis here. Can you read it?
Individuals who have received 3 or more doses of the vaccine in the past and who get a booster dose during wound prophylaxis, passive protection with tetanus immunoglobulin is not indicated irrespective of wound severity unless the patient is immunocompromised.
Okay, what it means is that even if it's a road traffic accident in a fully immunocompetent child, if the patient has received 3 or more doses, 3 doses, enough anytime, and you're going to give him a TT, there's no indication to give a tetanus immunoglobulin. This is the purple book, okay? This is the purple book, irrespective. This is page 179. I don't know what page. Okay, now this is what it is. This is not the end of the matter. Now we have therefore in an immunocompromised patient, what does it mean? Is not indicated irrespective of the wound and severity unless the patient is immunocompromised. What does it mean? In an immunocompromised patient, okay, and is not indicated irrespective of the wound severity, the patient, if he has taken tetanus 3 doses and you give a tetanus booster time, you don't require. That is page 179 purple book. And what does it indicate in page 445 purple book? We had read it during immunocompromised patient, the chapter on immunocompromised patient. Read it. Can you read it?
Tetanus prophylaxis in wound management. In a child with cancer who is on treatment and who then gets a wound, can be assumed that the antibody levels are inadequate. So tetanus wound management is as follows. In a clean minor wound, TT booster regardless of immunization status. All other wounds, TT plus tetanus immunoglobulin.
This is the purple book. This is how the purple book comes. You must understand that the immunization guidebook and giving tetanus toxoid or not giving tetanus toxoid has got very big medical legal consequences. Therefore, if you give an immunosuppressed patient and you don't give a TIG, telling that you read page 179, and then somebody else throws page 445 from the same book, you have the problem. This is a problem with immunoglobulin. But what is the right treatment? Now the question is, we can't postpone this. We can't postpone the decision. If the decision is taken by you, it has got a medical legal significance. Now, if you look at this is what is given in Nelson's textbook of pediatrics. Therefore, as they say, when you have problems, read the Bhagavad Gita or the Quran or the Bible. I don't read any one of them. I look at to my own conscience. That's a different. But if you read it, if you read the holy book of Pediatrics, for us, it was the holy book of pediatrics, Nelson's textbook of pediatrics, 26th edition, it gives you the same thing which is given in the purple book, more than 10-year last dose. You can go through it. I'm not going to go through it. It's the same, less than 3 doses, 3 or more classes. Therefore, that is the, can you read it?
Individuals who have received 3 or more doses of the vaccine in the past and who gets a booster dose during wound prophylaxis, passive protection with TIG is not indicated irrespective of wound severity unless the patient is immunocompromised. Tetanus vaccine is indicated in pain.
1 minute. Have they written about immunocompromised here? I think it is not from this. There's not written about immunocompromised here, is it not? Anyway, read the next sentence. Okay.
Tetanus vaccine is indicated in children who have received 3 or more doses in clean minor wounds, only if 10 years have elapsed. In all other wounds, only if 5 years have elapsed.
Okay, therefore, this is what we have learned. Anyway, Nelson also more or less agrees with that. Now, the question is, what does the WHO say? Now, go through it once more. I am going into a depth of it because it's a very important point. Okay, can you read through it?
Appropriate tetanus prophylaxis should be administered as soon as possible following a wound, but should be given even to patients who present late for medical attention. This is because the incubation period is quite variable. Most cases occur within 8 days, but the incubation period can be as short as 3 days or as long as 21 days. For patients who have been vaccinated against tetanus previously, but who are not up to date, there is likely to be little benefit in administering human tetanus immunoglobulin more than 1 week or so after the injury. However, for patients thought to be completely unvaccinated, human tetanus immunoglobulin should be given up to 21 days following the injury. Booster doses given more frequently than every 5 years are not needed and can increase the adverse effects.
Remember, whatever sentence is written here is from the updated recommendation of the Advisory Committee on Immunization Practice, United States, 2019. I purposefully put it up because it's not given anywhere else. How long after a wound can you give an immunoglobulin? I didn't. Now, this is very important because let me ask you, Amal has run away. I think only Gopika and Amal is there. Amal, I'm going to catch you because you should not be a danger to the public when you go and practice in the health service. Let me tell you one thing, Dr. Amal, when you are alone in the health center, in a health center or a dispensary, is the most challenging job. I'm telling you this again and again. You are there seeing 100 patients. Decisions have to be taken. There is no second opinion. You must know which patient to give what and which patient you can send, which patient you can drop. I have worked from dispensary, health service, private, primary health center, consultant in a tertiary care hospital, a referral hospital, worked as a teacher. The most challenging job is in the health center in a primary hospital. When you are sitting alone, and when there are 150 people around you. Now, Dr. Amal, you are sitting in the ER. So, you are sitting in the primary health center. Suddenly, a child is brought with a dog bite. The whole of the village will be with the patient. He has got multiple dog bites. He has got over many regions. He has got over his leg. It is all mixed with the blood and also dust and stone and everything. The patient comes rushing to you. You are in a health center. The rabies vaccine is available. Tetanus toxoid is available. Tetanus immunoglobulin is available. But the child, he went to Ayurvedic treatment. He followed the Ayush document. He went for Ayurvedic treatment. And he came back to you after a period of, say, 10 days. So what all will you give him?
Rabies immunoglobulin, rabies vaccine,
Okay.
TD vaccine.
Yeah, TD. Then will you give the tetanus immunoglobulin? He is completely immunized. If he is
No, sir.
completely immunized, more than 1 week, you will not give. Okay. After 1 week, you will not give. If it is non-immunized, you can give up to 21 days. That's what is written here. It's not given anywhere else. All right. Now, suppose the patient, what happened is they went to a health, you are sitting in a taluk hospital. The patient went to and took the tetanus rabies vaccine, but did not take the immunoglobulin because it was not available. He came here on the 10th day. Will you give the immunoglobulin?
Yes, sir.
No, sir. After
Yes, sir.
after 7 days of rabies, you are not supposed to give the immunoglobulin again. Remember that. These are important days. For patients with previously who are not up to date, there's little benefit in administering human tetanus immunoglobulin more than 1 week or so after the injury. That is tetanus. In rabies also, suppose vaccine is given, you will not give the immunoglobulin after 1 week. But suppose the vaccine is not given and the patient comes any time and it's a grade 3 bite, you will give both together. Because it's a little complicated. You must, it's not that easy. Okay. Now my question here is, we have done so much research here, and we have been talking about injury, tetanus. Why am I going on talking? I've been talking several times. Now, may I ask you, Dr. Amal, what's the WHO position on tetanus vaccination, tetanus injury? Any idea? What happened now? Ashwati also left, I think. Everybody can't remain in a class for 2 hours also. Okay. What is the WHO advice? Okay, read it now. Read what is given in the WHO immunization case of injury. Dr. Gobika, can you read it?
Yes, sir. Although adequate vaccination should provide sufficient protection against tetanus, physicians may give a dose of tetanus vaccine, preferably tetanus diphtheria (TD), low-dose diphtheria toxoid, in addition to other preventive measures if the injury is severe or the patient's previous tetanus immunization history is unreliable.
Although adequate.
In addition,
may give a dose. Okay, next.
in addition, TIG may be needed for prophylaxis in cases of dirty wounds and for incompletely immunized patients.
Okay, well, let's read through it carefully. Although adequate should provide sufficient protection, physician may give a dose of preferably tetanus in addition to the other injuries severe. Here he's talking is severe or deep. Okay, dirty wounds, severe wounds, he says give a TT, whatever be the immunization schedule. And then TIG if this is a dirty wound. Read what is given in the left, what I wrote it.
TT for severe injuries and TIG for dirty wounds and for all incomplete immunized. No mention of 5 years or 10 years. No relation to immunization status if deep or dirty.
If the injury is deep or dirty. This is the WHO recommendation in 2017. It doesn't talk of 5-year, 10-year gap. Therefore, whenever you have a road traffic accident, okay, if the immunization status is fine, he requires a TT, deep and dirty, no doubt about it. And for dirty wounds, in addition, maybe for profile case of incompletely immunized. Incompletely immunized means who have received less than 3 doses, tetanus immunoglobulin should be given. Which will you follow now? Therefore, my next question is, unfortunately, I didn't put the read the question now, which I put it up.
A 3-year-old child who has received the primary 3 doses of DPT in infancy as per the government guidelines, but missed the booster dose at 16 to 24 months, has a road traffic accident and comes with a deep lacerated injury in the foot. What is the tetanus prophylaxis for the child?
Given the answer also, I shouldn't have given. Read the answer.
As per IAP and Nelson's textbook of pediatrics, they need neither immunization with tetanus toxoid nor TIG. But as per WHO, they require both TD and TIG.
You understand the problem with this, okay?
Yes, sir.
See, the problem is as per WC, he is 3 years old. He has taken the 3 doses, therefore that's his immunized. 5 years have not elapsed since the immunization. Therefore, neither the tetanus toxoid nor the immunoglobulin is required, whatever be the wound as per IAP. Not only IAP is a standard world, but as per WHO, all deep lacerated wounds, dirty wounds, deep lacerated, dirty road traffic accident required both TD and TIG. They don't talk about the previous immunization status. But what will you do? Will you give or not give? Amal.
Will give, sir.
Amal also ran away, I think. Amal, what do you say? Will you give or not give?
We will follow Indian schedules.
WHO.
W.
Well, I would say that I would err on the side of caution. Definitely, I'll give the TD and I'll say TIG, take a second opinion like that. Because we are living in a different world. Defensive practice is a must. Because if the patient develops tetanus, you had it. Therefore, and especially when WHO has said it. But I don't think they can penalize you on that. But you must know that if the ER is not giving, they are right. If the ER is giving, they are right. Both are right. You must understand. I don't know how many of your consultants, how many of you knew before I said this to you, that there's a gross difference between what the WHO says and what the IAP and the Nelson's Textbook of Pediatrics says, in a medical case which can have medical legal repercussions like a wound injury. Just read through this and then we will go to the next one. Better to read. Gopika, can you read?
Yes, sir. A 3-dose primary series induces protective immunity in almost 100% of vaccinated infants. Although tetanus antibody levels are high after 3 primary TTCV doses in infancy, they decline over time. Data from serological studies suggest that a primary series of 3 TTCV doses in infancy plus a booster during the second year of life will provide 3 to 5 years of protection. A further booster dose, example in early childhood, and will provide protection into adolescence, and another booster during the adolescence will induce immunity which lasts through much of the adulthood, thus protecting women through their childbearing years. Protective immunity persisting for 20 to 30 years after a 6th dose of TTCV has been suggested in severe studies, several studies.
Why I'm making you read all this is there's a general consensus internationally now only a person requires only 6 doses of tetanus in his lifetime. Therefore, if a patient has received 6 doses and he comes pregnant, you don't have to give tetanus antenatally. But that is not followed in India. That's a different matter. Why you're concerned about giving tetanus again and again? Reactions are more when you give more than 6 doses. Read it now. Okay. Read what is given in pink only.
Every country should seek to achieve early and timely infant vaccination and maintain high coverage of a complete 3-dose primary series plus 3-dose booster series by the time of adolescence.
Okay, therefore this is what it is. 3 plus 3 is what they advise. Therefore, now what's given on the left you read?
Childhood and adolescent 4 TTCV only, and 1 dose, 1 booster during pregnancy, and 1 more dose after 1 year.
But that's what they advise. Now, read what is given in the pink only.
In order to provide lifelong protection, WHO recommends 3 TTCV booster doses, ideally with at least 4 years between booster doses. These should be given at 12 to 23 months of age, 4 to 7 years of age, 9 to 15 years of age.
Yeah, therefore that's what it is. They are given 3 plus 3 doses. 3 doses primary immunization, then 3 other booster doses. This is what you're supposed to give. Okay. Now this is the catch-up immunization of IAP guidebook. We have read it. The only thing I would corner you is if the last dose of TDAP has been administered more than 9 years, the adolescent TDAP is not. TDAP vaccine can be administered regardless of the interval since the last tetanus and diphtheria. There's some overlap here. I think I don't know what it is. Okay. All right. Now, the next question is, now at the end of the year, I want to ask you a question. 5-year-old child unimmunized. What's the vaccination dose for TDAP or pertussis alone? 5-year-old child, he's unimmunized. How will you immunize him? Diphtheria, pertussis, tetanus. Gopika, how will you immunize him? Alone, catch-up immunization. It's easy. What's the problem?
Child should.
Yeah. Go ahead.
Should receive a series of vaccinations, sir. Before 7 years, we should receive the series of vaccinations.
Which is the vaccine? DTwP.
Yes.
Yeah, that's what we give. Okay, DTwP. Okay. Then he will receive TDAP at 10 years and TD every 10 years. Okay. You understood? That also you should say. TDAP at 10 years, TD every 10 years as per IAP recommendation. Some Western countries give TDAP every 10 years. But now they say that's too costly, therefore it's not given. Now the next question, he has already received one dose of TD. Okay, he gave one dose, he received at 6 months or something, or 6 weeks or 10 weeks. No other immunization. What will you do?
Again,
5-year-old child. He has received one dose. He has not received a. This is not given anywhere, but I wrote it on my own. You give 2 doses because you continue the immunization. 0 and 8 weeks, because when you give 2 doses, better to space it to 8 weeks, because this will act as a booster. You can give up to 4 weeks also. TDAP at 10 years and TDAP every 5 years. Now, my question here, the child is 9 years old. How will you give him?
9 years fully unimmunized only, sir.
Fully unimmunized. Fully unimmunized. Sorry, fully unimmunized.
Then we'll give TD.
TDAP.
TDAP.
TDAP first dose, then
Then after 10 years, TD.
no. You are not given the primary immunization, Gopika. You gave TDAP, that's the first dose. Then see how I am putting you into difficulty. This can be very, very common. You understand? Once you go to the, if tomorrow Amal is getting posted in Malappuram, he might get the same thing. Or post even in Kannur. You know that the DTP, DPT immunization status in Malappuram is only 60%. Can you imagine this? 60 to 70% in Kerala. Many places in North India, it's only 60%, 50% like that. But you will get this question very commonly. I don't know why they are not asking such questions to you. Instead of asking MRI.
After 4 weeks, again, we have to give it TDAP.
Yeah, okay.
Then TD vaccine every 10 years.
0, 6 weeks, 6 months. You will give TD. Okay, TDAP first. This is a primary. He has not received primary immunization. Therefore, 0, 6, and 6 months. Therefore, that means 9 years. TDAP, TD, 10-year TDAP, and TD every 10 years. That's what you do. Therefore, you understood that. He requires, yeah, the TDAP can be given not taking into consideration whatever be the previous immunization. Therefore, you give a TDAP. But there is something else coming up. Received one dose of how will you treat him? Again, the answer is 0, 8 weeks, TDAP, TD, 10-year TDAP, and TD every 10 years. You understood what I'm writing? It's not that simple as you think. One dose of. Did you get it?
Yes, sir.
Okay. Late I got it. Now he's 15 years old. I'm sorry, 15 years old. He's completely immunized with DTP 6, 10, 14, 18 months, 5 years, and TD at 10 years. He has not been given TDAP. What will you do? The mother comes and says, doctor, is everything fine? Because I found that there is a problem in immunization in India. Therefore, I am worried. What will you do? Is there anything to be done? Will you give him a TDAP or will you not give him a TDAP? He's coming to PRS hospital. No, he has received all the immunization as per government protocol. 6, 10, 14 weeks, 18 months, 5 years. The government only talks about TD, doesn't talk about TDAP, and therefore 10 year received. He's a very good.
Then after no immunization needed.
No immunization required. Okay. That is TDAP. See, if a patient has not received any TDAP at any time, at least give him one TDAP. That's the answer to it. And I think we are catching up the dose 250. Anyway, we'll go further also. If a completely immunized, you give TDAP every 10 years. Therefore, this way, see, go through it. When you go back, go through it again. Therefore, this is why I say that catch-up immunization is not that easy. Many people make many mistakes in it. They give unnecessary vaccination. She should have received at least one TDAP, you understand. And that is the recommendation. And if a 15-year-old child comes and says, takes your opinion, ready to pay it, why not give him one TDAP, which is about 1,200 rupees or something. It's not like 4,000 rupees like excessive. And then he requires TD every 10 years, IAP recommendation. Now, how do you give a patient H influenza? Now, the question here is hip vaccine. Amal, if a patient comes unimmunized, the child is 7 months old. Is the hip vaccine any different? Hepatitis B. Amal is let loose in the community. I have given him pass mark in BCH. He is now a consultant practicing in Malappuram. Okay. And unimmunized.
We can give up to 5 years.
Okay. How will you immunize him? 7-month-old child.
It is just like that 7 month we have to give the first dose, then
Yeah.
4 weeks apart,
okay.
2 doses.
So you give the primary doses, 3 doses. Then when will you give the booster?
Booster at no booster is there.
Booster not required?
For
Booster,
1.5 years.
16 months.
What about Gopika? How will you immunize him?
Yes, sir. A booster dose also required at 16 to 18 months.
And therefore, you will give 3 doses at 7 month, 8 month, and 9 month at a booster. Now, suppose the child is 13 months old, or is more 1 year, past 1 year, 12 months completed, 13 months. He's coming to you unimmunized. How will you immunize him? I'm asking you immunization, Amal. They can't go to anybody else. There's nobody else. Even the DMO may call you and ask you, Dr. Professor Amal, please tell me. I'm asking you immunization. I'm not asking you MRI, not asking you ECG. I'm not asking you even X-ray chest. I'm asking you immunization. Okay, read it now. You read it from the beginning to end. Amal, you read it, punishment for you. Okay, read it. Okay. You read it from vaccination schedule for HIB as follows. Remember, downwards.
The vaccination schedule for H influenza B is also follows: less than 6 months, 3 doses at an interval of at least 4 weeks, and 1 booster at 16 to 18 months. 6 to 12 months, 2 doses at an interval of 4 weeks, and 1 booster at 16 to 18 months. 12 to 15 months, 1 dose and 1 booster at 16 to 18 months. More than 15 months, 1 dose only. Catch-up vaccination is not recommended for healthy children above 5 years. However, vaccine should be administered to all individuals with functional or anatomical hyposplenia, irrespective of the age. HIB vaccines are now used mostly as a combination vaccine, that is pentavalent vaccine.
Okay, now if I am the examiner, I will definitely keep this as one of the points. Remember, Amal made a mistake. 6 to 12 months, only 2 doses are required. Okay. So about 12 months, only 1 dose is required and 1 booster. What is not written here is the booster should at least be 8 weeks after the first dose. And above 15 months is 1 dose. PCV also follows the same thing. Only thing is PCV is not 15 months, but is 24 months. Why are we giving less vaccine than what you give below 6 months? Because maternal antibodies are not there. And also the immunological system of the patient is better, is in a better situation. He can respond better. 2, he might have had infections. He might have already had HIB infections, subclinical infections, which would ask as primary dose. This is the explanation. 6 to 12 months. before 3 months. 6 months means before completed 6 months. If you start, you have to give like before, like you give at 6 weeks. 6 to 12 months, only 2 doses. 12 to 15 months, 1 dose and 1 booster. Booster is always given. And above 15 months, only 1 dose is given. And above 5 years, H influenza is not given. Remember this. This is given by Nelson's textbook of pediatrics, also gives this in the same way. Okay. Now, Amal would have been a dangerous person in the health center. Now, coming to PCV, there is a question here. Now, PCV, I would, if I ask you to read, it will go through the whole thing. You will find same thing, 6 weeks to 6 months, about 6 months. They have written 6 to 12 months. Here, they have written 7 to 11 months. Instead of 15 months, the upper dose is 23 months. Okay. The rest is same. Here, 15 to 60 months in the Haemophilus influenza, years is 2 years onwards. There, the bifurcation happens at 1.5 years. Here, the bifurcation happens at 2 years. Are you hearing this for the first time? I don't know. Therefore, what happens is it is PCV13 is what you call Prevenar. PCV10 is Synflorix. 10-valent PCV is what you call as the Serum Institute. What's the name of the vaccine? Pneumocil. Okay. Now, if you take this, all are below up to 6 months, 3 dose, 1 dose booster, 12 to 15 months. Therefore, that's very simple. 7 to 2 doses, 2 doses. Okay. That also is very simple. 1 dose during 12 to 23 months. Okay. It is again 2 doses, but they should be 8 weeks apart. When you give only 2 doses, the second one acts as a booster. Therefore, the minimum interval should be at least 8 weeks. Okay. Above 24 months, the problem arises if you give PCV13, only 1 dose is required. PCV10, 2 doses are required. PCV10 is Synflorix. What about the Pneumocil, Dr. Amal? Universal immunization program. You are sitting in a health center. A child comes to you with unimmunized. How will you give Pneumocil? 2 doses, 1 dose, 3 dose, no dose.
3 doses.
2 doses.
Both of you are dangerous people. You can be sued.
2
Okay.
doses with a booster.
Read the last one. Last sentence here, what I've underlined.
The DCGI has approved 10-valent PCV.
10-valent PCV, I don't know why they wrote 10. That is
PCV10.
called Serum Institute of India, SII. Okay.
For active immunization in infants from 6 weeks of the age group for 3-dose regimen, dosing schedule 6, 10, and 14 weeks. The WHO has approved it for active immunization till the age of 2 years. ACVIP endorses WHO recommendation of its use till the age of 2 years.
Remember this very, 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 very carefully. That is, post pneumococcal vaccine can be any vaccine to be given in India. It has to be tested in that particular schedule in India. That's the rule. Then only the DCGI would, what is the DCGI? I think is Drug Controller, Government of India, or I don't know what exactly it is. I think it is Drug Controller. Only if it is endorses, you can give it. If you give a vaccine which is not endorsed by the DCGI, any reaction, even a febrile seizure and encephalitis, you can be in trouble. Nobody will protect you. Nobody can protect you also. Even if tomorrow, I say Dr. Lalita or somebody comes and says this, the judge may not give you the right because DCGI has not approved it. How can you give a vaccine to a child? Therefore, here, but the WHO has approved Pneumocil up to 2 years. Now, PCV10 and PCV13 have all been internationally accepted. PCV13 above 5 years also. If you want to vaccinate an adult, it is PCV13, not PCV10, because they are not studied. 10-valent PCV is what is available. Therefore, WHO till the age of what they call 5 years, you can give the other vaccine, but pneumocil can be given only up to the age of 2 years. Even that, there's no study in India. Okay. DCGI is not 6, 10, and 14 weeks alone. Only primary immunization they have studied. I think they have studied 1.5 years also, but I'm not too sure. Now, what is the pneumococcal vaccine given in most of the health centers now? Amal?
PCV10s.
PCV10. Gopika? Pravanar is what is given in the Techad Hospital. What is given in PRS Hospital? Pravanar is given. Also, pneumocil is given. Synflorix is almost out. Whether we will be talking of pneumococcal. Pneumocil കൊടുക്കുന്നുണ്ട്. India മുഴുവൻ pneumocil ആണോ ഗവൺമെന്റ് national immunization program? See the point, see the irony of the situation. I am taking a class from my side for you. You are DCH students. We are talking of immunization. Look at the people who are absent. Go, our Ashwati came, he has disappeared. Lesima came, she has disappeared. You will qualify just like Amal coming out of the hospital without knowing what is the vaccination given in the government hospitals today. Read this. Can you read it?
Sir, which one,
Anything?
sir? Schedule.
No, what has come up in the red? Anything has come up in the red?
PCV 14.
I think B limited. That's the name. The name is Nubo Vax 14 or something. Okay.
Yes. Studied only in 3+0 schedules. IAP does not recommend for boosters in 3+1 schedule. Cannot be given in catch-up immunization.
Or cannot be given in catch-up immunization. Let me tell you, why am I picking up PCV 14? There's a big talk on PCV 14. I am not going to go into that. What is surprising to me, a person like Amal is graduating without knowing that in 2014 May, the government of India produced a circular telling now onwards all pneumocil will be replaced by PCV 14 in many states. In that state, Kerala is not included, but soon it might come. They will not supply any new pneumocil. If you have the old pneumocil, PCV10 Serum Institute, you can use it. But now onwards, PCV 14 alone will be supplied by the government of India. Did you know it? And you are passing out of DCH without knowing it. But the funny thing about it is it is tested in India only in 3+1 schedule, 3+0 schedule. What do you mean by 3+0 schedule? Can you tell me what it is? What is 3+0 schedule, Amal?
6 weeks, 14 weeks, 9 months.
No, 6, 10, and 14. Only the primary
Oh.
dose. What you said, 6, 14, and 9 months is known as what schedule? 2+1 schedule. Okay? 2+1 schedule. And what we give in our hospital is the best 3+1 schedule. That's 6, 10, 14, and 1.5 years. That schedule we give for all vaccination except HepB vaccine. Therefore, cannot be given in catch-up. Therefore, but what has happened is, instead of it, the IAP has said it has only been tested in does not recommend the booster 3+1. What about 2+1? There's no study done in 2+1 in India. And in the universal immunization program, how is pneumocil given, Gopika? What's the schedule for pneumococcal vaccine?
6, 14, and 9 months.
Yeah, therefore 2+1 schedule is given. Now, what has happened is the national, without doing a study of 2+1 schedule, without it being published, they have introduced it in May 2014, 2024. They have introduced the new PCV 14 vaccine. And the IAP is keeping quiet about it. They are afraid to ask the government why are they doing it, because it's against ethics, is against our own rules. The DCGI has not approved it. It is only 3+0 schedule which is approved, not 2+1. And you cannot give it for booster doses. Therefore, remember this, PCV14 should not be given for booster dose. That's what IAP clearly states. PCV13, PCV10 can. PCV10, I mean Serum Institute can be given. Anyway, that is something beside the point. Therefore, remember all this will come up in practical point. But I just put up the difference between this. This is here 12 months. Here it is. But in the cutoff point for Haemophilus influenza is 15 months, while the cutoff point for PCV is 24 months. And nobody gives for normal children about 2 years. That is it. Therefore, that's what is given in, I think, in Nelson's test book also corresponds to it. Now, let me ask you the final question, and I will. Now, you must tell me the dose immunization of a child unimmunized who's 5 months old with HepB and PCV vaccine. 5 months old unimmunized.
4 weeks apart, 3 doses, and booster dose at 1.5 years.
1.5
16 to
years.
18.
Yeah, and is there a dose at 5 years? No, we don't give a dose at 5 years, isn't it? Okay. There's a 3-dose interval of 4 weeks, and 1 booster should be applicable to all PCV brands, but you cannot give it for PCV14. Booster PCV14, you should not give, okay? Because it's not done. That's what I have written, okay? The DCGI has approved for active immunization, 6 weeks age group, 3-dose, has approved it for 10. That's what I've written. Okay, now next, 7-month-old child unimmunized.
2 doses at the interval of 4 weeks and 1 booster at 16 to 18 months.
Okay, that will be the vaccine. 62 doses at the interval of 4 weeks, 1 booster 16 to 12 months, 2 dose 4 weeks at the second year of life. Great. If the child has received a single dose of HEB below 6 months, what happens when he comes at 7 months? He has received 6 weeks, but beginning is the important thing. You understand? 7-month-old, he has begun his immunization before. Therefore, you would here for PCV, it is written age at first dose. Therefore, this fellow who has taken a single dose, he has taken it. Therefore, he will require the 3 doses. You understood that? Beginning, age at the first dose is important. 6 weeks or 7 to 11 months or 12. But this fellow comes here, not here. All right. Therefore, he will receive 3 doses. That means he will receive 2 more doses of PCV at 4 weeks interval and a booster second year. Regarding a hepatitis, he should also, same should apply for HEB vaccine. That's not given very clearly regarding HEB. Remember, the age at which it begins is what decides the number of doses you give. Okay. Because here it is written vaccination should do as follows: below 6 months, 6 to 12 months. Here is 7-month-old baby, but he has began an immunization below 3 doses, therefore 6 months, therefore he will receive 3 doses. I hope I am clear on this. All right. Okay, now rotavirus will be the next one. Already we have overstepped the time by 10 minutes. You came 15 minutes late. Now there are only 2 people here, Amal and Gopika. I don't know whether I will continue the classes like this. Because where is Lasima? Where is Ashwati? Where is Faris? Where is Mohsin? Where is Mohsin today? I had stopped the recording. Yeah, recording.